As I have told you, it's a very time-bound examination and it's a very objective kind of examination. In the clinical case scenario, we'll be having around 25 questions, and we are allotted with around 30 minutes of time. So you will be given 1 minute, approximately 1 minute for each question. My request to you, if you are not okay with any question, you can pass it, or else I can give you only 1 minute for one particular questions. Then I will make you stop and then go to the next question, because I'm supposed to complete all the questions within that 30 minutes. That's number one. In the case-based scenario also, there will be 15 questions, and the 15 questions will be there. You'll be given 15 minutes. So I'll expect you to answer within 1 minute, and after 1 minute, I'll proceed to the next question. So sometimes I might need to stop you. Please don't take it otherwise, because the exam format is like that. With that, we'll start. Dr. Raga, if you're okay, we'll just start.
Okay, sir. You can hear my voice, huh?
Yes, I can hear you. Thank you so much.
Okay, thank you, thank you.
We'll start with the clinical case scenario. So I'll be giving you one case vignette. Please read out the case vignette. And once you are finished, let me know. We'll start with the questionnaire. Your entire clinical case scenario will be on this particular case vignette. So please remember and try to remember whatever is there. I'm starting the timer as well. Let's start the timer.
Yes, sir.
We're done with the show. Can you?
Yes, I read this. I read that.
So I hope you must have gone through the case vignettes. The first question to you: what are the practical challenges in resuscitation of this patient? Please try to be to the
What
point, focused.
meant by challenges? This patient is hypothermic, so patient response to medications and will be less. So dose of medications and intervals should be adjusted. Rewarming should be done up to 35 before considering failure of CPR. This patient should should get prolonged resuscitation.
Is there any difference in resuscitation protocol in patients with hypothermia as
Yes,
per the ACLS protocol? So that is what
yes.
the examiner wants to know.
Dose and the interval of medications. This is one issue. The other,
Okay. Question number three: what are the salient points in the resuscitation protocol in the hypothermic patient?
what means salient?
Points in resuscitation protocol in
What
hypothermic.
salient? What means salient?
So how does it resuscitation protocol different in a hypothermic patients compared to a normal other patients? Is it same or is it somewhat different? Something different we need
No,
to know.
no. This is same question in all three questions are the same.
Yes, yes, because you have not got the answer. Okay, we'll proceed. So, what are the prognostic factors determining the overall outcome in a post-drowning hypothermic out of hospital cardiac arrest? So again, if we talk about the challenges you need to say again everything. Like this, an out of hospital cardiac arrest is a problem. Hypothermia is a problem that you have said rightly. Post drowning cardiac arrest is a challenge. So to some extent it is different. So how do you prognosticate these patients?
As a prognostic factor determine overall outcome in post-drowning.
So what
Is
is
it
the prognosis? Anything like timing?
hyp-
Anything that will determine the overall prognosis whether the patient will survive or not, patient will remain bedbound or not, patient will remain comatose or not. How do you determine the prognosis in a patient with a cardiac arrest?
I don't know this one.
Can you proceed? So this patient ROSC, so ROSC was achieved after 65 minutes of CPR. The patient was intubated and ventilated during resuscitation. After ROSC, the patient was shifted to the ICU. He was comatose, but he became hemodynamically stable with time. Question 5. What will be your resuscitation care for the initial 72 hours? So that means what investigations you will send for this patient initially and what will be your plan of treatment in initial 24-48 hours. What investigations will you send for this patient? Are you there, sir?
Yes, this is a routine investigation, ABGs and renal light and CBC and culture, bank culture and CT brain and CT chest. We have to do exclude infections got from uh,
Why do you need to send culture for this?
CK, huh?
Why do
Because
you need why do you need
this
to send
patient
culture?
aspirated can be aspirated, patient can get infections. Huh?
Initial. So I'm very particular about the for the initial 72 hours. Like initially when somebody achieves ROSC after cardiac arrest. What investigations will you send?
I will send ABGs. I will send this one
Yes.
CK. Huh? I will send lactate,
Yes.
uh, CBC, renal light,
Okay.
uh, CT. I think for this
City of
patient can
what?
be traumatized. This patient chest X-ray. This patient can go to ARDS.
You will do a city of what?
CT chest and CT brain. I am telling CT brain and CT cervical, huh?
Okay, city chest and city brain and
And cervical spines.
cervical spine. Okay.
Ban CT can be as the patient can be traumatized. Ban CT trauma protocol.
Trauma protocol. Okay. We'll do as per our trauma protocol. Okay.
But plan
And
for
what
treatment of the initial. This patient should be rewarmed up
okay.
to 30, more than 35.
Okay. Then any other treatment will you start? Okay, we'll proceed. So you have seen the labs for this patient. Your day one labs come. You can see the labs. Your CBC you told you will send. We have given a value of CBC. There's some renal parameters, some liver parameters that you must have sent. So those lab parameters have come.
Mhm. Okay.
Patient remained on a ventilator in the ICU. After 3 days, the patient started developing fever. His oxygenation started to worsen. He started requiring norepinephrine support. His GCS is E1, VT, M2. His day 3 labs have been provided to you, and the chest X ray has been shown as in the field. So, you need to tell me, you'll have to explain this current clinical evolution, and you need to identify three medical problems here. What is this patient having? So day three in the ICU.
This patient is shocked. Can be septic shock.
Okay, very
He
good. Very good, sir.
This patient have acute kidney injury,
Very good.
liver injury,
Very good, sir.
so multi-organ system failure, and this patient persisted comatose. So this patient is very liable to be a brain dead patient.
Okay.
So bad prognosis. And we should start for brainstem death document. M2 still,
So he's
patient still
M2, so we cannot.
sorry. He's still M2. Yes, yes.
Okay.
So
We'll
we
go to the
can
next question, sir. So what will be your plan of management in this scenario? What investigations, what further investigations will you send? What treatment will you give? How will you resuscitate? Because you told the patient in septic shock. What fluid will you give? What antibiotic will you give? And how will you monitor progress?
This patient now 3 days, 3 days post, 3 days in ICU, so we have to consider hospital acquired infections. So we
Very
should
good.
cover according to local antibiogram.
Okay.
Uh, Guided, we have to start broad spectrum antibiotics, including anti-pseudomonal antibiotics.
Okay. Very good.
Uh, uh, should we start also this one anti-MRSA if it is MRSA MRSA score
So
is
what investigations will you send for this patient?
ban culture, ban culture to can aspirate and the blood cultures and urine culture. Uh, should we consider also
Okay. You will send
is
blood
this
culture and you will send which culture you
yes
send? You will send blood culture, you told, and which
I
other
told tracheal aspirate I'm telling and urine culture.
tracheal culture and urine culture and blood culture. Okay. Okay. Good.
Uh, hmm?
What treatment will you give?
We'll start anti-pseudomonal antibiotic with like patient has also bilateral infiltration.
Hmm. Hmm.
We should do lung ultrasound. It can be this right-sided pleural effusion. If it is like this, we should have taken. We should take pleural fluid also for chemistry and culture. Uh, we should
How will you
start
resuscitate this patient?
what?
Sorry. How will you resuscitate this patient? Somebody who is developing septic shock. What fluid?
Patient IV fluid. We have to start IV fluid.
Which fluid will you
Uh,
give?
Normal saline, we can give normal saline to
What's the line?
30. We'll start as the bolus 30 ml per kg, guided by dynamic measures of fluid responsiveness,
What is the dynamic
uh,
measure of fluid responsiveness?
like leg passive leg rise testing and inferior vena cava collapsibility and pulse pressure variability and other echo parameters like stroke volume uh, variability
Okay. How will you monitor progress
index.
of this patient? How will you monitor progress of this patient?
Lactate by lactate level by clinically by MAB we should consider MAB more than 65
Hmm.
mean arterial pressure and
Hmm.
lactate level if it's coming down within the few hours next resuscitation uh,
Okay.
and urine output also if patient
We'll go to the next
kidney
question. Does
okay
this patient have AKI? You have already told yes. I.
yes I
What are the
uh-huh.
stages of AKI?
According to clinical classification
Yes. Yes.
we have we have 5 stages
Hmm.
so stage one, we are rising of the uh, creatinine by 0.5% within 48 hours. Stage two is doubling. There's two consideration: rising of the parameter of the creatinine and urine output less than zero point 0.5. I don't remember
Okay, no
the
problem.
stages.
What stage this patient is in AKI? What stage of AKI this patient is in at present?
Stage one, I think.
Okay. Question number nine. What do you think the probable cause of acute kidney injury in this patient?
Patient have septic shock.
Yeah.
This other things like um,
Okay, patient in septic shock.
Right?
So that's the cause. Any other cause apart from the septic shock?
Yeah,
Any other cause?
yes,
Can you feel that there might be any other cause of AKI in this patient? Patient was
yes.
hypothermic couple of days
Damage
back.
to damage injury or what's called mm, mm, rise of CK,
Okay,
like compartment syndrome or
sure. We'll proceed.
hypoxia or prolonged hypoxia also for a long time.
Sure. We'll proceed, sir. Day five.
No?
We'll proceed, sir.
Okay.
Let's come to the day five. Patient remained hemodynamically unstable. He is on dual vessel pressure. He is intermittently febrile. He started to become oliguuric. His GC is now E1 M1 VT. His FO2 requirement on the ventilator increased to 70%. His cumulative positive balance of 12 liter in 5 days. His day 5 labs have been provided to you. You can see hemoglobin, the complete blood count picture. You can see the renal parameters. You can see the liver parameters, and you've been provided with an arterial blood gas report. Done.
Yes, sir.
Does this patient require renal replacement therapy? Yes, no.
Yes, sir.
Okay.
Patient has
Why do
persistent
you think so? What are the
this
indications of renal
patient has
replacement?
hyperkalemia persistently, and this one has metabolic acidosis, severe metabolic acidosis in spite of maximum circulatory support.
What are the indications of renal replacement therapy in ICU? What are the common indications of renal replacement therapy in ICU?
Yes. Persistent hyperkalemia, persistently acidosis, acute pulmonary edema,
Very good.
uh, septic shock.
Okay.
Mhm.
Okay. We'll proceed. What are the different types of renal replacement therapy? What are the different types of renal replacement therapy?
We have intermittent hemodialysis and CRT, continuous renal replacement therapy, and slow uh,
Okay, one is intermittent hemodialysis, others are
continuous one, and
continuous
slid.
smoke renal
Oh,
replacement therapy, CRT, other
yes, and slid, but
SLADE. Okay, very good.
yes,
Any other form, you know?
peritoneal, but peritoneal is not commonly used in ICU.
What form of RRT will you prefer for this patient and why?
A CRT because the patient is hemodynamically unstable.
Good. What vascular access will you use for this patient and what is preferable site of cannulation?
We prefer jugular,
Okay,
uh, internal jugular access.
right side, left side.
Right-sided is preferable to left side.
Okay. What are the different modalities of CRRT?
CVVH يعني continuous venous hemodialysis, continuous venous HDF, and hemofiltration. CVVHD, CVVHDF, CVVHF.
Okay,
As I
good.
know.
How do you adjust the dosing of CRRT and how do
Those
you
we should calculate the uh, dose by 20 ml per kg and divide this one between dialysate and uh,
how do you calculate different dose in CRRT?
I'm telling 20 ml per kg is the dose, and
What is the
we
dose?
are
Sorry, sorry.
starting with 25, huh?
What is the dose?
20,
Sorry, I missed it. What is the dose?
20 ml per kg, as I remember,
20 ml per kg per.
per hour. Sorry, per hour, yes.
Good. Okay. And how will you calculate that effluent dose in CRT?
I'm telling we are giving half dose as a dialysate, and this is the effluent dose. I'm telling this is the effluent dose,
Hmm.
20 ml
Hmm.
per
Do you know the
kg.
formula of calculation of effluent dose?
What again, please?
Do you know the formula of calculation of effluent dose? Okay, we'll talk about
It
it.
is dialysate pre-dilution plus post dilution plus ultrafiltration.
Okay. What are the different anticoagulations used in patients on CRT?
You have this heparin or citrate.
Okay.
Different. Hmm?
Okay. Any other anticoagulation apart from heparin and citrate? Okay. What anticoagulation will you use for this patient for running CRT?
Local
Hmm?
local anticoagulation with citrate, I think.
Which anticoagulation will you use this patient for? You will use heparin or you will use citrate?
I think I will use citrate.
Okay. Do you know what is filtration fraction?
It should be kept below 25, I think. And this is يعني
Why it is important?
for half life of the يعني for the lifespan of the filter, to keep filter life extends more.
Okay.
So,
How will you determine the dose of citrate and anticoagulation? And what monitoring will you use whenever you are using a citrate anticoagulation?
we are using serum ionized calcium and serum calcium. This ratio between ionized calcium and total calcium. Uh, we are determining that we are starting empirically, but by one dose. But I'm forgetting now all those things. I am sorry, but it's okay to
You will ionized calcium. You will do from which place? You will check from
post filter.
which filter? Both filter means
Yani from patient side, from return access.
from return and access.
Yes.
Anything else you want to monitor? Okay, proceed. So this patient required one cycle of CRRT for 24 hours. The patient hemodynamically became better, requiring minimal vasopressor support over the next 2 days. And kidney function also improved partially over the next 2 days of time, but patient remained unresponsive. ECS was E1, VT, M1, and you suspect a possible brain death state. How do you evaluate this potential brain death patient and how will you diagnose a brain death state?
Yeah. If patient is GCS 3 more than 3 hours, more than 6 hours, and we have definite cause for this, so we have to start for brain death documentation by uh, actually first we have to patient should be hemodynamically stable and electrolytes should be within normal range. Uh, then we will go to brainstem reflexes, examine twice.
Hmm.
Uh, by two consultants 6 times apart.
So how you
Uh,
diagnose a brain death state? What are the three cardinal criteria to diagnose a brain death state? Okay, you have heard the name of apnea test?
okay, we will pre-oxygenate and take one ABG before starting. Then we will put catheter in the ETT to with inflow of low flow oxygen. Then we will take ABG every 10 minutes. If patient and we observe all inspiratory efforts. If no inspiratory effort for the patient and with the rise of CO2 20 millimeter mercury, this considered a positive apnea test, and if patient uh, got hemodynamical compromise, we have to abort the apnea test at any time.
Do you do apnea test commonly in your ICU, Dr. Raga?
We are doing, yes.
Okay, okay, okay.
What are the
What are the
confounders? What confounders means? I don't understand.
confounder means there are certain situations where the validity of the apnea tests are questioned or apnea test may not be done. So the other situation where apnea test, the
Oh,
other
this patient,
has to be avoided before conducting an apnea test.
yes, if this patient developed hemodynamic compromise during the test, so I have to abort the test directly and reconnect the patient to ventilator. If patient taking inspiratory effort, so apnea test become negative and we have to reconnect.
What are
Uh,
the conditions that we'll have to meet before conducting apnea test?
like if patient have severe hyponatremia or
Good, very
uh,
good. What temperature we'll have to keep?
more than
More
36,
than
I think. More than 36.
36. Okay,
35 to 36, I think.
very
We
good.
cannot do, yes.
Yeah, okay, then next. Other things?
Uh,
You have to keep the temperature, central core temperature more than 36. Any other things that you will have to keep before conducting an apnea test?
I don't know thyroid profile,
Thyroid profile?
uh, uh,
I doubt.
but it's not a routine. Uh,
I doubt it is there.
I doubt, yes, yes, I doubt it.
Any other preconditions we have to meet before conducting an apnea test?
Mm, mm.
Okay, what are the role of ancillary tests to diagnose a brain death step? Do you know?
If the apnea test is doubtful or cannot be done, so ancillary like CT angiography or
So name
uh,
three, four ancillary tests for which are used for the diagnosis of brain death state.
again. So please question.
Tell me three to four and name of three to four ancillary tests
Ah,
which are
okay.
used to diagnose brain death state.
CT brain angiography.
Okay.
This other one is radionuclide, uh, radioactive. What's called
Okay.
CT
Uh,
MRI? I don't remember.
okay. We'll proceed. How will you communicate the current clinical status to the relative? What are the key principles of communication or communication to the relatives in this scenario? Or you can take it in another way. I am suppose I'm the relative of the patient. How will you communicate the patient's status to me, being a doctor?
Actually, we have to do multidisciplinary team with all members included in patient management, and we will have a meeting, and we will introduce ourselves. I'll introduce myself as
Very
ICU
good.
doctor. Then I will ask what they know about patient condition. I'll start to explain patient problems from the beginning, and I'll explain what efforts not done for patients and how was the prognosis. And I'll show that this patient is already diagnosed as doing this, and there is no hope. Uh, I'll show empathy with the patient relatives. Uh, and I'll ask at the end, I'll ask if there any doubts they want to confer.
Okay.
Okay.
Can this patient be considered for organ donation?
I think can be considered.
Hmm?
I think can be considered for organ donation.
So will you counsel this patient's relative for an organ donation?
I think so, some separate team is should be included in this one
Hmm.
for communication for organ donation.
Okay.
But
Okay. So that ends our CCS part. I hope. Do you want to take some break, or we can proceed for the case-based scenario, Dr. Raga?
uh, I just because I received call from the our ICU, so I just need 2 minutes to confirm what they want from me. If you can,
Sure,
I'm
sure. Take the
sorry,
two
sorry.
minutes and just let me know when as soon
Yes.
as ready.
Okay. Okay.
Okay, so we'll proceed to the case-based scenario. In the case-based scenario, we'll be having 15 questions. For each questions, we'll be having 1 minute of time, and
Okay,
we'll
sir.
finish this off.
Yes, sir.
Yes. So the first question, restart the timer. Again, so this is a 26-year-old male admitted with a history of road traffic accident. He's hemodynamically unstable, ongoing resuscitation. The chest X-ray has been done, so you will have to describe the chest X-ray, and after that you will have to the next question. Please.
This patient have معلش this one. What I see left lung collapse. Uh, معلش just my mobile is showing something.
Okay, left lung collapse. Any other thing you can
I am
see?
sorry. I am sorry. I am sorry. I will just adjust my brightness because wait 1 minute.
Yes.
This patient has multiple rib fractures
Very good.
and left lung collapse
Which side?
and huh?
Which side
Uh,
refracted?
rib fractures
Which
left
side?
side
Left
mainly.
side.
Left side mainly with left lung collapse
Okay.
and shows like there is pneumomediastinum.
Okay.
There is left ICD.
Okay. Very good.
There is. Uh, I could not see if the patient is intubated. The tube is uh, not showing. Uh, mm, mm.
What will be your plan of management?
As this patient have multiple fracture ribs in different levels, I feel this patient will be having a flailing chest and will be uh, hemodynamically unstable. This patient should be uh, يعني sedated and given muscle relaxant, sedated and mechanically ventilated. Uh, uh, help this patient to got definite control for rib fractures. Uh,
Question two. 45-year-old gentleman, again, road traffic accident, came with low GCS, is breathless, hypoxic when arrival to a hospital, emergency intubation done in ER, CT brain was done after intubation. So we can see the CT brain over here. Can you please describe the CT scan?
Patient shows diffuse brain edema
Okay.
with subarachnoid hemorrhage, as I see, with
Okay.
symptoms of increased ICP with multiple brain contusions.
Brain
As
contusion.
I feel this, but this is subarachnoid. Some
Hmm.
some hyperdense opacities is there.
How will you grade severity for subarachnoid hemorrhage?
There is
Is there
Fisher
any grading system?
modified Fisher score and Hunt and Hess, huh? Hunt and
Okay.
Hess score
Very good. Very good, sir.
is so this if it is including interventricular or no or thick or thin. So this looks like no interventricular subarachnoid and it is thick. So I feel it's grade 3.
Okay. Any other clinical grading scale you know of for patients with subarachnoid hemorrhage? You talked about modified Fisher scale. Any other scaling system? Do you
Hunter and Hess, I think,
okay,
and
Hunter
like
scale?
Galasco.
What is that?
Galasco. There's Galasco score. Or there's some other third score. I don't remember.
Okay. So this is the chest X-ray of the same patient. We did, as you could remember, so we did both CT scan and the X-ray. So X-ray of that patient is this. Describe the chest X-ray and what will be your plan.
This patient upper right lobe collapse,
Okay.
uh, and it shows intra this tube in the main bronchus.
Okay.
So withdrawal of the tube, 2-3 centimeters to the main trachea.
Good. Okay. So there is a 25-year-old female with a PCOD on OCP admitted with a chest pain, mild hemoptysis, and breathlessness since yesterday.
BCOG means معلش BCOG means
Polycystic ovarian disease.
polycystic ovarian disease and OCB or
Yeah.
contraceptive pills and okay admitted with chest pain, the mild hemoptysis and breathlessness since yesterday ECG diagnosis. This is bilateral pulmonary embolism,
Okay. How will you decide your
ma-
plan
uh,
in this patient?
main trunk, huh?
How will you decide? How will you decide your plan of treatment in this patient?
If this patient is hemodynamically stable or unstable.
Okay, very
If
good.
if patient is hemodynamically stable, we should start anticoagulation. Even this patient can start on new oral anticoagulants or heparin with warfarin or vitamin K antagonist till 5 days. Then we will withdraw enoxaparin or heparin and continue on after we reach the target INR.
And if the
Uh,
patient is hemodynamically unstable, what will you do?
if patient is hemodynamically unstable, we can go for thrombolysis,
Okay. What agents
thrombolytic.
will you use for thrombolysis?
We are giving alteplase.
The dose of that
Uh,
is
dose is 30 milligram within half an hour. Then I don't remember the dose.
okay. We'll go to the procedure.
Here.
Five.
Okay.
A young lady admitted with fever for 2 days with one episode of seizure in the right upper lobe and right upper lobe weakness. What is the diagnosis? We've been provided
Right.
with small brain for this lady. What is your diagnosis and how will you manage? So first diagnosis, anything?
And right upper limb weakness only. Huh? There's like mass in the right hemisphere. Uh,
Okay, we'll proceed.
no, I did not get it.
Uh, I'm sorry. So describe this graph. What is this graph?
This flow, sorry, was one of pulmonary function tests. Is,
This is a pulmonary function test.
no, this is flow volume loop.
Slow volume loop. Very good. So what
So
do you see
this
in this slow volume loop?
this
Wait to
patient have leak.
very good. This patient has leak. However,
Yes. Hmm?
what actions?
This volume is not returning to what question please? What action you will take? I check for the whole ventricular circuit and cuff of the ETT.
Okay. Okay.
If the patient, okay.
We got the question number 7. Sorry if I am interrupting you multiple times. So,
No,
but
no problem. What mode of ventilation? This patient is volume targeted or volume targeted, volume control, volume control. This patient is volume controlled.
very good. Can you please
As,
describe the
as
respiratory problem here?
describes the respiratory problem. Okay.
What do you see? What do you understand from the well?
Peak pressure is high, so this patient it looks like ARDS
Okay.
patient. Sorry. Uh-huh. Tidal volume. Yes, this patient is it looks like ARDS patient, high peak pressure and low tidal volume is there. Mhm.
so what do you think the complaints of the patient's respiratory system? Static complaints of the patient's respiratory system.
Static compliance, so is plateau minus PEEP divided by tidal volume.
So
So
what will be your
32 minus 6 is 40, is 20, 28, 26. It is like 100.
what is the normal static compliance in a patient?
Mm, 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 mm. I
Okay.
don't.
Will be your intervention in this kind of patient?
Uh, Intervention high PEEP with low tidal volume increase rate to maximum tolerating up to 30-35. Already respiratory rate is 30. معلش. R35 can also decrease IE ratio يعني increase IE ratio prolong inspiration uh, so it, we can prolong inspiration and make it low tidal volume is this high PEEP and we
Okay.
can go to a burning and we can make give a muscle relaxant and we can consider ECMO extracorporeal oxygenation.
So we could proceed to
There is
question
also
number 8.
no
Yeah, that's okay.
which okay.
We have proceeded to question number 8. What mode of ventilator it is?
This mode of ventilator. So this is pressure control mode, as I feel. Pressure control mode.
Sure, it is pressure control mode.
Not sure.
Okay. So what is the problem in this patient?
Okay. This patient looks like have auto beep.
No. Okay. We'll proceed.
No, no.
No.
طيب.
So there's a 65-year-old male came to ER with severe crushing chest pain while being evaluated. He collapsed suddenly. CPR has been started.
This is risk return of spontaneous circulation.
Very good. Very good. What is the role of continuous waveform capnography during CPR?
This patient will show effective CPR from differentiate effective CPR from ineffective. It show return of spontaneous circulation. It show
To understand
dislodgement
whether
of.
your
Hmm?
CPR is being effective or not, what should be the target
CO2
ET?
should be more than 20, I think.
Okay, good, good, thank you. So this patient has acute kidney injury post cardiac surgery. He has persistent metabolic acidosis. He's oliguric for the last 6 hours. He's on vasopressor. The ECG has been shown like this. What is your diagnosis and how to manage? Any idea of the ECG?
The patient can't sine wave is there, so and the
So what will be your
broad Q
diagnosis?
R. Hmm?
What will be your diagnosis?
We should get the electrolytes and correct the acidosis. What is this diagnosis?
Okay,
This is bundle branch block. I don't know. Complete heart block.
okay.
Okay.
Let's see.
56 years old, admitted with sudden onset rushing chest pain. Perspiration, colics, and baseless hypotension.
What's your diagnosis?
Info acute
Good, good. Acute?
inferior wall MI
Cerebral MI?
with septal MI also, huh?
Tongue MI? Okay.
ST segment elevation MI in inferior and septal wall. Septal, huh?
What will be your immediate plan of management?
So this patient should be taking loading of antiplatelet
Yes, very
and
good.
given say يعني analgesia and considered for primary BCI if the patient is within 6 hours from starting of chest pain
Okay,
should be shifted for primary BCI.
we'll proceed. 47-year-old female admitted to the hospital with the diagnosis of B cell NHL. She had non-oliguric renal dysfunction with anemia and transaminitis on admission. Received first cycle of R-CHOP. Uh, Post chemotherapy, renal function worsened and she developed pancytopenia. So we have been provided with a lot of laboratory values. Uh,
Tumor lysis syndrome.
Very good. Tumor lysis syndrome. What made you think it's a tumor lysis syndrome?
Uh, this one we good hydration and respiratory case uh, we can use uh, what else?
Apart from hydration, any other thing?
Respiratory case, I think, huh?
Any other thing apart from hydration you can do for preventing tumor lysis syndrome?
Allopurinol we can give.
Very well, thank you. Very good. 35-year female, known case of Sjogren's on an intermittent steroid. Admitted 2 weeks of fatigue, poor appetite, nausea, vomiting, and confusion. The bilateral pain abdomen. The vitals have been provided to you. ABG has been provided to you, and the bunch of investigation has been provided to you. Let me know if you are done.
bilateral pain, abdomen.
Yes.
Respiratory temperature 38.
Your first question is describe the acid-base balance.
Because this is metabolic acidosis. High
Right.
on ثواني.
Anything you want to add in the metabolic acidosis?
High anion gap. I am calculating the anion gap.
Please look up it.
144. This is normal anion gap metabolic acidosis.
Normal
Mhm.
LNG.
Yes, it looks like 10 only, 10 anion gap. So this is normal anion gap metabolic. Yes, normal anion gap metabolic acidosis.
Okay. And what will be the next best test for the diagnosis?
acute kidney injury, hypokalemia. يعني renal impairment, hypokalemia is
So
there.
what will be your next test for the further diagnosis? What test you will order next?
Adrenaline, this one, uh, cortisol,
Okay. So if because the patient had normal
ACTH stimulation test or
no, so okay, so because the patient had normal NN gap, you asked for an urinary electrolyte to check for the urinary NN gap, and the urinary electrolytes values have been provided to you. Now, what is your diagnosis? What is the cause of normal NN gap metabolic acidosis in this patient?
adrenocortical insufficiency. I think it can be this one. يعني Addisonian crisis if he stopped the steroid. Addison,
Any other thing you can think of?
sepsis, can, normal anion gap. I don't. Renal impairment.
Go to question number 14. As in ALF means
There is one question. One question before I didn't see this CT.
okay.
Yes, this one.
Yeah.
You
Could you
are asking about this one. You are asking about this one. I didn't.
yes, what is your diagnosis? I have asked.
Ah, I thought you are talking about the previous case. I saw. Sorry. Urine electrolytes, creatinine, sodium.
So it is a part of the same question. The patient with a normal level of metabolic acidosis. It is a
Uh-huh.
continuation of the same question. It's a
Uh,
continuation of the last question only.
okay.
Hmm. Okay. We'll proceed.
Continue.
Question number 14 is an acute liver failure. Patient is on CRRT on ventilator with an effluent dose of 3 liter per hour. He is on citrate anticoagulation with a citrate dose of 3 millimole per liter. He suddenly became hemodynamically unstable with bradycardia, QT prolongations. ABG has been provided to you. The CRT setting has been shown on the screen. Uh, uh, what do you think the problem is? What is your diagnosis and how do you manage?
Yeah, this is some citrate toxicity, but I don't remember this. Sorry. So forgive me, boss. This one.
Okay, this is a toxicity as per you, and how will you manage if you feel it is a citrate toxicity? How will you manage citrate toxicity?
I think we should increase the dose of infused calcium and reduce the rate of citrate. But I don't. Uh,
Okay,
we have to reduce dose of citrate and increase calcium, but I don't remember exactly. Because patient is acute liver failure also, so lactate is high. Okay.
okay. The last question. The 16-year-old boy came with a history of chronic cough and fever for 2 days. The sister did an ECG and has shown you the ECG. Can you please
This
describe?
patient, this patient have inverted leads or dextrocardia.
Okay, very good. So we will see that the leads are there properly or not. If it
Sure.
is leads
Yes.
dextrocardia, very good. What can be the most likely diagnosis for this boy if this patient has dextrocardia?
Chronic cough and fever. I don't know really.
Okay, no problem. So our question.
What? Those patients have some this dextrocardia liable for cystic fibrosis or something? I don't know.
It's okay. We'll discuss.
Okay, I am sorry for inconvenience. I am not just prepared, but I wanted to try to
No
put me in
problem.
the
No
mood.
problem. No problem, Dr. Raga.
Yes, yes,
So
yes. I am sorry. I'm very, very sorry for
no problem. No problem. You did the certain part of yours are quite good. The certain parts of probably we'll discuss more where
in
we can.
debriefing, huh?
So maybe there will be kind of debriefing sessions we'll conduct with you. I think this exam coordinators they will let you know that at what point of time we'll organize a debriefing session. In the debriefing session, we'll discuss what are the strong points and what are the weak points and where are the scopes of improvement which you should work on further so that you can do you do best in your exam.
Many things from the questions. Many subjects I felt I know, but when trying to express it, it shows some difficulty. So
Yes.
this is my usual. Yeah, some many things we are practicing, but to express an exam shows some difficulty, and I cannot. Yani,
That happens to a lot of candidates in the exam, but again,
mhm.
ultimately this is an exam. So in the exam, whatever you express, that has been taken as an whatever you know. So unfortunately,
So
it's like that.
if you don't mind, please send me video of this of my exam so I can assess my difficulties if you
Definitely,
don't mind
definitely,
this
we'll
one.
do that. We'll do that for
Yes.
sure.
About the phone debriefing, I want to see my attitude and I will manage those things personally. So please, if you can.
Definitely,
Thank
definitely,
you.
we'll do that. We'll
Thank
do that, sir.
thank
We'll do that.
thank you. Thank you.
Thank you,
Thank
thank you,
you.
thank you, Dr. Raga, for
Thank you.
joining.